Stay tuned for the afternoon session. Thank you.
In the spirit of customer satisfaction, we've done a survey at the Simon School of Business of our MBA students. We asked them which one is more difficult, the lecture just before lunch, because you know students never have breakfast, or the lecture just after lunch. And what the students said, the worst is the lecture instead of lunch. So I won't do it to you, okay? Really, there's nothing more exciting than watching disruptive innovation stories in real time. And to do just that, to share with you many innovations taking place as we speak, we brought in 7 speakers when we are going to follow the Aspen Institute model. The Aspen Institute model brings world-class experts. Each one of get 3 minutes, kind of give me the gist of your innovation, share with us the most exciting project you're involved with. And we're really very fortunate to have here a top-of-the-line array of speakers. So the way it works, after 2 minutes, the red light in front of you becomes yellow. When it becomes red, it's 110,000 volts coming into the seat, okay? So stage is yours. Please give our panelists a big warm hand. Thank you very much.
2 minutes. 2 minutes?
Okay, so please.
Okay. Good afternoon. And this has been quite a stimulating morning, hasn't it? So I'm Tom Chuck. I'm the president and CEO of Healthix. Healthix is the largest of the health information exchanges in the state of New York. So I'm going to say just a little bit of grounding, and then I'm going to talk about an innovation that I want to share with you. The bit of grounding is, you know, you heard Senator Daschle and you heard David Brailer talk about health information exchange. The state of New York has put a big investment in health information exchange. The state health department has both funded and is regulating health information exchange, and there's coordination of it through the New York d.health collaborative, whose chair, David Klein, is with us today. So there's a big investment in this in New York State. Healthix is the largest of the regional health information exchanges. We hold data of 10 million people here in New York City and Long Island. That's continually updated by over 150 provider and health plan organizations that are constantly updating the data electronically with every patient encounter. And then the patient can give consent for their provider or their health plan to access their data for purposes of care management or for purposes of treatment. So that the control of who gets access to the data is in the patient's hands. One of the things that we do then that's most significant, if I think about the kinds of innovations we've been talking about here this morning, having to do with aging and aging in place and finding ways to support the individual continuing to live in the community instead of being in a nursing home, for example, is that someone needs to be in a role, or typically is in a role, of care management. It could be the home care agency, it could be the health plan, it could be an organization like an accountable care organization, it could be a hospital-based care plan. And later you're going to hear from Dr. Lynn Richardson some of the ways that Mount Sinai's geriatric emergency department does follow-up care for individuals as well. So that the trick then is, how do you get access to information about the person in the community when they're not within your 4 walls anymore? So one of the very simple things that we do is the patient can give consent for their healthcare provider to be alerted by us if that patient should present simply in an emergency department anywhere. There are 53 hospitals that are constantly feeding data to Healthix. If you show up in the emergency department, you get registered in their admitting system, and that alert will get to Healthix before the doctor even sees you in the ED. We can transmit that information then to who's the care manager, which could be the home care agency or et cetera. And then they can know to intervene with the emergency department and say, we have information we'd like to share with you. Similarly, the emergency physician might, as a routine thing, consult Healthix to see, is there already pre-existing information on this person that can help me understand what their condition is so I can treat them and release them to home with proper follow-up care rather than admit them as an inpatient, which can be very destabilizing. So that's one innovation. As I say, we're one of 8 health information exchanges in the state, the largest of them, but currently we're in the process of being able to connect and have data fluidity among us. I'd like to encourage anyone here who's in the space of either acquiring or providing treatment services or care management services that wants to participate in HealthFix, come see me or my colleagues who have a booth on the floor, and we'd be happy to talk with you. Thank you.
I'm going to break the rules and step down here. My name is Kevin Fickenshire. I am the founder of Creo Strategic Solutions. We're involved in strategy and leadership development. 3 minutes isn't very much time, so I created my own PowerPoints. One of the things that you'll notice from my slide is that there's a whisk up there. That's because I think I'm a really good cook. Actually, it's because I stir things up. And so what I want to do this morning or this afternoon is to stir things up just a little bit, because I've been this morning listening to all of the discussions. I've had a number of one-on-one discussions, and it occurs to me that we have a lot of possibilities. We have a lot of individual pieces, and they're not tied together. And if we don't tie the pieces together, we've got nothing. We're not going to solve the problem. And I can tell you that we won't get the attention of the C-suite, because that's where I've sat for the last 30 years. C-suite doesn't want individual products. They want solutions to their problems. And I think that's one of the things that is a challenge for us. So we're stuck in a period of a lot of pilotitis. And I've heard about a lot of pilots going on. And I think that's a problem. That's a problem. And we need to figure out how to get beyond that stage. And so the question that I started asking myself is, so why is this occurring? It's occurring because I think there's 6 major impediments. One is that we have an impediment related to the financial incentives. I think the healthcare system does exactly what the healthcare system is incentivizing it to do. It's very good at sniffing out where the money is, and it provides solutions that go in that direction. So the quicker that we can move from a volume-based model, the more I do to you, the more I get paid, to a value-based model, the healthier I keep you, the more I get paid, the quicker we can make that transition is the quicker that we're going to solve the problem. That's one. 2, we have a workforce problem. The average age of nurses in this country is 56 years old. One third of all primary care providers over the next 7 years are going to either retire, become disabled, or die. If we think that we can solve the problem by training a bunch of nurse practitioners who are age 56 to take over for physicians who are going to be 1/3 less than they are today, I think we are crazy. We need a different model. And technology is at the core of how we're going to solve that problem. So we have a workforce problem. Second issue is we have a communication problem. It was mentioned this morning about the whole issue of interoperability. We should be standing up and demanding interoperability rather than trying to encourage it. We should be absolutely livid that it's not happening. And the healthcare industry has not done that. So interoperability is the third issue. Fourth issue is that we have this issue called licensure. It's something where if I'm in Massachusetts and I happen to be up in New Hampshire across the border, I can't provide services, and I can't for sure go to Maine because I'm not a Mainer. So, you know, it's all those kinds of issues. So the licensure problem of having state-based licensure is an issue. And the compact that's been developed by the Federation of State Medical Boards is a step in the right direction, but we need to more aggressively adopt that so we can solve this problem. So that we don't run into the problem that we have in Texas, where they said, oh, if you're not from Texas, if you haven't seen the patients, then you can't provide the services. That is a bogus kind of an approach, and that gets to the next issue, which is we have this guild mentality. And from my perspective, one of the things I keep telling my physician colleagues, the guilds are dead. The guilds are dead. It's because the knowledge is out of the box. And it's not only dead for the physicians, it's dead for the nurses. It's dead for the pharmacists. The guilds are dead. We should accept it. We should figure it out. And at the core, developing technology infrastructure is going to help us solve that problem and actually provide better services. Final two things really is that we need to have better focus. And what I mean by that is a lot of the outcomes or results that we drive to are process outcomes versus derivative outcomes. And so that whole issue needs to be looked at. And then finally, having a universal patient identifier, something that that's a battle we have to take on. We have to solve that problem, because without solving that problem, we're going to have all this disparity of data. It's not going to be in the right place at the right time for the right person. And there are ways to solve that so that people can have security, so that they can have confidentiality. That is a technical problem that can be solved. And we should be at the forefront of helping to solve that. So that's the reason that I think we have a problem with pilotitis. And that's the reason I think we need to move from providing lots of little individual products to really providing a telecare solution, because care is a continuum, a whole series of products that are tied together and work together to solve the problem. And as Bruce Leff told us this morning, 25% I think is the figure that you use roughly of the care. It could be done in the home. I actually think it's higher than 25%. I think it's probably at least a third, if not greater. So with that, we need to solve these problems that are impediments and not put on the blinders and look at our own individual product. Thank you.
Hi, I'm George Gibson. That doesn't actually look like my slide, but it'll do while I start talking. The reason that the slide that I hope is there has to do with why I'm talking about healthcare. Frequently, I will show up to someplace. I was at the medical director for the state of Medicare and Medicaid for the state of Wyoming recently. Went in and said, "Hi, I'm here from Xerox. I'm here to talk to the director." They said, "Oh, no, it's down the hall. That thing keeps jamming, and I don't know where to put the toner in it." And mercifully, I was able to solve that problem. But actually, Xerox has quite a large business in healthcare and has for some time. There we go. There are the. So I'm not going to read all of those, but that's actually why we care. We are at the part of Xerox that I represent, the Palo Alto Research Center, actually has all of these businesses as our customers, and quite frankly, a broader range as well, as we have diversified to do contract research and much more government research as well, and bring to those the power of about 400 researchers in the area. So I can't obviously tell you what all of those folks are doing, but I'm going to tell you about some of the things that relate to some of Xerox's core competence. So we have people who are working at the fundamentals of microfluidics for super low cost, paper-based medical testing. We have folks who are working on non-contact sensing and remote sensing. We have people who are working on communication. Now, probably you've had one of these. This is called a patient information bulletin. I'm not sure who that patient is, by the way. This is clearly written by a lawyer, right? The last time I took one of these and asked my favorite web-based tool, what reading level competence would you have to understand this? The answer was, well, about 25th grade. So since the average reading level in the US is about 6th grade, you see a bit of a problem, right? We have folks who have very highly developed skill sets trying to talk to folks who don't, and they don't share a common language. This is actually a big problem, and because it's a communication problem, it's one that Xerox knows some stuff about. For instance, we've worked ongoing in medication adherence. Medication adherence, right, drives $300 billion with a B dollars worth of avoidable medical expense into the healthcare system this year, the U.S. medical system. 40,000 peer-reviewed articles. You can't go a month without hearing about a new app that takes care of this problem. In 10 years, the problem hasn't changed. But because we're not actually communicating with what people actually use as decision criteria around medication. Yes, you can remind people to take their medicine, right? There's no end of fancy little bottles and apps that will call your phone and tell you to take your pill. But if the real reason you're not doing it is like, you can't afford it, or you don't really believe you need it, then these things aren't actually going to help. While forgetting is about 10% of this problem, the giant problem is not somebody who forgets occasionally to take a statin. It's a person who's decided not to take statin therapy, right? So if you connect to the person's real needs, their real information requirements, and provide information to them in a way that they understand, you actually stand a much better chance of doing it. So that's one of the areas that, in fact, we're working in. And trying to stay away from the, please fill out this survey. I need to talk to you. I need to understand what your literacy and numeracy are. Let me give you a brief test. So does that sound like a good idea? No, of course not, right? So we need to learn how you want to be communicated with, what will be convincing to you. Oops, I need to shut up. So I will.
Okay. Thank you so much, Ray and Avi, for having me. I'll talk a little bit about Tiger Text. And before I do, just by a show of hands, how many of you here have heard of Tiger Text? Just raise your hand. Okay, so a handful. Tiger Text is the leader in secure, HIPAA-compliant messaging for healthcare. And that messaging is on your smartphone, tablets, other types of portable devices. A few years ago, back in 2010, when we launched the company, we raised a little bit of funding. We reached out to every major hospital and healthcare facility. And at the end of 6 months, we had 0 healthcare customers. So we tripled our efforts and we ramped up our team. And at the end of 6 months, we had 4 healthcare customers. And today, Tiger Text is in over 5,000 healthcare facilities around the US, including 4 of the top 5 for-profit hospitals. And so a lot has changed since 2010. And a few things that have changed are that when we launched the company, questions about the use of mobile devices and the use of tablets in hospitals was still being discussed and still being debated and still being evaluated. Now, BYOD and mobile devices are ubiquitous, and every major hospital that we talk to is developing a plan. What do we do? How do we leverage the fact that doctors and nurses and administrators all have mobile smartphones? So let's talk a little bit about Tiger Text. First of all, I'll highlight how Tiger Text is changing the nature of care. Basically, Tiger Text is doing 3 things that can improve the quality of care, whether we're talking about seniors or other types of patients. The 3 ways Tiger Text tries to help is by, number 1, improving the quality of care, number 2, lowering the cost of that care, and number 3, improving efficiency by decreasing times and response times. So I'll highlight 2 things on this slide. And Andre, are you back there? Okay. So number 1, when folks now check into a facility, Tiger Text is being used in a HIPAA-compliant way to actually notify the relevant caregivers that somebody is being admitted to a hospital. And if you scroll down a little bit, you'll see that as the person is being transferred from the front desk, and keep going, Andre, we'll keep going down. I'll walk around a little bit. When they get transferred to radiology, we can now have seamless communication with the entire caregiving team, including the radiologist, the primary caregiver, and any specialist that might be involved. Every one of these messages can include photos or x-rays or EKGs. And if you scroll down a little bit more, you'll see that the result is that the doctor is able to look at the x-ray, and all this is done in minutes as opposed to hours and days, and as opposed to having to rely on other methods that may not be as efficient. So that's why we're pretty excited. If you scroll down a little bit more, Andre, you'll get to the bottom. When the person is discharged, a message can be sent, and then go to the very bottom, Andre. You'll see that the result of all this is, again, keep going, is that a physician, first of all, nurses can save up to 4 hours per day with secure HIPAA-compliant messaging, just based on the fact that they don't have to run around and wait for charts to get transferred. Physicians can now see more patients. Prescription refills can get cut. And there can be an 80% reduction in emails and phone tag, and we can someday help make sure that pagers get removed from hospitals, which I think it's about time. So that's really what Tiger Text is all about. I'll wrap up by just emphasizing a broader point, which is when Avi and Ray and we talk about providing care to whether it's elderly, seniors, or any member of the patient community, the fact that we now have mobile tablets, wearables, I think we're not just at a change in our healthcare, we're actually at an inflection point. I think this is a sea change. And I think we're going to see a whole lot of revolutions coming in the next 10 years. And I think we'll look back at this period as being a pivotal one in the healthcare space. Thanks.
Good afternoon. My name is Lynn Richardson, and I'm an emergency physician and a health services researcher at Mount Sinai here in New York City. Mount Sinai is a very innovative healthcare organization, and in 2012, it opened the first geriatric emergency department in New York City. And later that year, we were fortunate to secure a Round Care Healthcare Innovation Award from CMS to actually implement some new and innovative models of care for older adults in the emergency department. There is no chance of my even describing that suite of innovations in the time that I've been given. So I will tell you it covers everything from dealing with patients at the end of life and making sure that they get the type of care that they need, to connecting high-functioning community-dwelling seniors with senior centers in their neighborhood to decrease social isolation, and just about everything in between. So there's a whole suite of emergency department-based care coordination. But the main one I want to tell you about today is really our active management of the emergency department to home transition. As emergency physicians face the ever-rising bar for who actually we are allowed to admit to the hospital, we are often faced with an older adult, which, as you've heard, may have multiple medical problems, be on a dozen or more medications, not really have an acute need for hospitalization or even for an emergency visit, but rather than just saying, go home, goodbye, good luck, JediWise has developed a transitional care team with a nurse practitioner, a social worker who will actually continue to work with that patient and provide support after they leave the emergency department to make sure there's that warm handoff to whoever is providing their ongoing primary care. And one of the tools we've used to do that, actually Tom alluded to, is an event notification system that was created for us by our regional health information organization, HealthX. And using their health information exchange, if one of the patients who's being managed by my JediWise transitional care team shows up in any of those 53 emergency departments in our area, my transitional care nurse gets a real-time message that they're in the ED and can get on the phone and talk to those providers and avoid having that emergency department repeat the entire workup, which was previously done in our emergency department, and talk about all the services we put in place for that patient to be safe at home, and avoid an admission really through this enhanced communication that's been made possible by the health information exchange. And I think I am now going to set a precedent by stopping on time and turn it over to my colleague.
For the invitation to speak today. I'm also at Mount Sinai, emergency medicine physician and clinical informatics researcher. At Mount Sinai, I've been involved with the CMS Innovation Award grant as well. As part of that program, Mount Sinai as an enterprise has been looking into the telemedicine area. And one of the demographics that we initially had written off as not tech savvy enough to actually use telemedicine with is the older adult population. But as the CMS Innovation Award went on, we realized that there's actually a growing demographic within the older adult population that is in fact quite facile with Skype, and FaceTime to communicate with their grandchildren or children. And so we, towards the end of the grant, implemented a telemedicine solution to follow up with geriatric patients after they've been discharged from the emergency department. And as a result of this implementation, we found quite a bit of patient satisfaction in utilizing mobile apps to follow up with patients, usually on a high definition video consult basis with a nurse practitioner that's specially trained in geriatric emergency department care transitions. We have seen a reduction in our 30-day readmissions as a result of the JettyWise program. I think that as baby boomers continue to age, the demographic that's already facile with Skype, FaceTime will become, the expectation will be that their physicians would, of course, follow up with them via a connected health solution. So that's our innovation. Thank you.
Good afternoon. Thank you. I think I'm going to steal your minute. My name is Jonathan Shankman. I'm Senior VP for Clinical Innovation with AMC Health. AMC Health is a consultative telehealth clearinghouse. We are not a manufacturer of technologies, but rather we customize packages of the very latest and best of breed technologies with clinical and other support services designed for individuals bearing chronic illness living in the community to best connect to their care teams. Now, at the core and the heart of all of the many applications is a web-based analytics platform, a dashboard, that is forward compatible to practically any data source. Now, that data can be biometric from monitoring devices. It could be self-reported symptom and behavior information from telephonic IVR or mobile apps. It could be medication adherence data from smart pill boxes we've integrated, smart inhalers. And we're now looking at additional technologies to integrate. We don't even know the potential yet, whether it's passive monitoring like you heard earlier for activities of daily living, access monitoring, are they sitting up in a chair all night, are they accessing the fridge, and sleep quality information from sleep telemetry systems. The point is that all of these very disparate data elements coalesce onto a single web record for that patient with wraparound analytics to provide the widest possible view of that chronic disease narrative for the patient. Now, the common thread through all of our many successful programs over our 10 years is that, and no two have ever looked alike, is that they all have the singular focus of how can technology be leveraged to make the home an effective and practical locus of care. Now, this emphasis on the home is deliberate. I often compare chronic illness to a movie, and it's easy to forget that although so many scenes do take place in the hospital and in the ambulatory clinic setting, the vast majority of scenes take place in the home, away from a pair of clinical eyes. But that is exactly where these insidious pre-acute, pre-decompensatory issues begin to fester. And as you know, everything we do in healthcare is reactive, pretty much. All the money, all the efforts is to put out raging house fires. The problem with chronic disease, which is about 80% of the dollars, is really better described as the smoldering wiring behind the wall. So we have long known, if we're ever going to move the needle, we need these processes to detect pre-acute conditions far enough upstream of those adverse events that we can steer these patients to less costly care venues, whether it's an alteration of medical management in the home or get that patient into the physician's office, rather than, of course, find out about it in the ER. Now, of course, long story short, I would love to spend hours about all our outcomes. Just in the last 3 years, we've had 4 peer-reviewed publications testifying to the efficacy of these solutions, whether it's remote management of diabetes, telehypertension programs, remote management of complex heart failure, or the integration of these technologies into post-acute care, showing tremendous ROI and very significant improvements in clinical and utilization outcomes. So what have we learned after it's almost 8 million patient days of remote monitoring? Lesson number 1, this can never, in the end, be about the technology. This is about information and what gets done with this information. In other words, process. Lesson number 2, more data is not necessarily better. And where my organization is now investing so much of our resources is in the development of those clinical decision support tools, working both internally and with external partners in machine learning and data science and other areas of artificial intelligence for more nuanced predictive alerting and pattern detection so that these become scalable. And lesson number 3, at the end of the day, no matter how accurate this information is, if a nurse care manager in a cubicle perceives this as an impediment to his or her workflow, I promise you it'll never get used. And so we invest, again, so many of our resources to understand how these processes get threaded as seamlessly as possible into clinical workflows and clinical best practices in such a way that it does not subvert what these individuals and these professionals are already doing very well. So thank you.
Thank you very much, Tom, Kevin.